Hello, and thank you for joining us for our Tardive Dyskinesia Risk Factor Symptoms and Treatment Options webinar today. Tardive dyskinesia affects more than 500,000 Americans. An estimated 1 in 4 people who take antipsychotic medications for many years develop this problem. One main challenge of TD is lack of awareness of the condition and treatment options. This panel, featuring a TD clinician, a person living with TD, and their care partner, will cover the basics of TD. So that's going through the symptoms, how to recognize the conditions, how to advocate to your provider about TD, and what more needs to be done to ensure people experiencing TD get the care they need. And joining us today, we have Dr. Roger Mcintyre, who is a renowned bipolar disorder and TD expert, and also a member of the Scientific Advisory Board here at DBSA. We have Jeff Fox, who is here today to share his story of living with TD along with his care partner, Cheryl. And I'll let them introduce themselves a little bit, starting with Dr. Mcintyre.
Great to be with you, great to be with my colleagues, and greetings everyone joining us. I'm a psychiatrist by training, professor of psychiatry in pharmacology at the University of Toronto. And I've been co-chair of the Scientific Advisory Board for the DBSA, and great to be in that role with DBSA. And over the years, more than 20, in fact, close to 25 years, my goodness, time flies, I have been providing care for people with mood disorders, often who are taking treatments that are associated with tardive dyskinesia, which our focus is today, something of which I've taken an academic and clinical interest in for more than 2 decades. So great to be with everybody.
Thank you. And Jeff, would you like to introduce yourself to our audience?
Sure, Dave. Thank you for having me. My name is Jeff Fox. I've been struggling with tardive dyskinesia for over 15 years. I've also been part of DBSA for almost 15 years, so it's approximately the same time, maybe a little bit longer. It's just been a struggle until fairly recently to understand what TD was and the fact that I even had TD.
And Cheryl, would you like to introduce yourself to our audience?
Hi, my name is Cheryl Fox. I'm Jeff's wife. We've been married for over 37 years, and I've watched him struggle with this as far as the body movements, spasms, twitching, and trying to find out what's going on. It's been extremely frustrating after consulting with many physicians, psychiatrists, doctors, etc. over the years.
And also with us, Josie Cooper, the Executive Director of the Movement Disorder Policy Coalition. Welcome, Josie.
I'm Josie Cooper. I serve as Executive Director of the Alliance for Patient Access, an organization that works to improve policies related to patient-centered care and patient access. We launched through the Alliance for Patient Access about 5 years ago, the Movement Disorders Policy Coalition. So MDPC, as we call it, supports policies that will improve patient access for those living with movement disorders, including tardive dyskinesia. And so we work with about 21 partner organizations to address policies related to care, related to access, and related to awareness and stigma as well.
Dr. Mcintyre, both Jeff and Cheryl experienced some frustration with dealing with TD. Can you tell our audience exactly what TD is, what causes it, what the symptoms are, what treatment options are out there for people?
Yeah, absolutely. Let me begin with a bit of a historical context. Tardive dyskinesia was first described in 1957 and first labeled in 1964. So this has been around a long time. And what it is, it's a condition which is associated with the exposure to what we call dopamine blocking agents. So there's many different types of dopamine receptor blocking agents. In the world of psychiatry, we often use antipsychotics, which are really used for different purposes. They're called antipsychotics, but we use them to treat depression and anxiety, many other conditions. And these medications, that is the medications we prescribe, but also there's other medicines that block dopamine, are associated with TD, which is an abnormal, involuntary, repetitive movement. As you've heard, it can involve many different parts of the body, including the face, the body, the upper extremities, lower extremities. And the key thing is that it's involuntary and it can be quite distressing. As you've heard, it can be quite impairing. Unfortunately, in the absence of treatment, it's not reversible in most cases. We know it's common, affects somewhere between 10 to 30% of people on the low end and the high end who are exposed to these treatments. So it's an abnormal involuntary movement. It's associated with some of our medications that's affecting a lot of people and affecting them very negatively.
What are some treatment options for people living with TD?
Yeah, and the first point I want to start with is we have treatment options. That might sound, well, like, okay, what's the significance of that? Well, this is a big time problem. But as I said, the first cases of tardive dyskinesia were first described in 1957, and the first FDA approved treatment for TD wasn't until 2017. That's a long time we had to wait for treatment. I can tell you firsthand, working with many families, many patients over the years, we just kind of were so frustrated. We were so demoralized that this was happening because people need the medication to control the symptoms, to live their life. And then we got this problem. And we tried all kinds of things and, frankly, it was a cross my fingers approach, to be perfectly blunt with you. We didn't really have a treatment. And in 2017, the FDA approved what's called VMAT2 inhibitors. In VMAT2 inhibitors is a category of medicines that not only effectively treat tardive dyskinesia, but they also, in fact, treat it very effectively and very quickly. And this is an important category of medications that people should speak to their healthcare providers about. So we've had them now for, I guess, just over 5 years or so, this being 2022, which isn't that long in the history of TD, quite frankly. But look, we were so pleased when we had it because there's different types of treatments that work and treatments that work really well. And they work really well. And that's been, frankly, it's been a game changer for so many people that I provide care for.
Thank you for that, Dr. McIntyre. Jeff, I want to get some perspective from you. When did you realize that you may have been suffering from tardive dyskinesia?
For many years, I was on a medication, antipsychotic, that was associated with weight gain as well. And I didn't know that probably was the start of the tardive dyskinesia. But I very self-conscious about both the weight gain and the body movement. So it was primarily focused in my neck and my shoulder, and it was constant. It took many years. We went to orthopedic doctors. We went to just all sorts of doctors to find out what it was. And the frustrating thing is, after we found out, there was just not a lot of education. Like Dr. McIntyre said, it wasn't well known within the medical or community. The psychiatrists didn't know it. The other doctors didn't know it. Everybody tried to treat it for something else except tardive dyskinesia. And I finally found out from the VA that I might have it. I went to a neurologist and they validated it. And then I started going on medications that eventually controlled it.
And Cheryl, for you, Jeff started to experience the symptoms of TD. What were some of the things that you noticed early on?
That he had a lot of spasms or movement in his neck and shoulders. I called them twitching like this, very, very pronounced. And at the point where I guess he had a full-blown episode, it was like an epileptic attack where his arms were flailing. He could not sit still. His neck was moving. I mean, it was really frightening. And then he went to the ER, mm-hmm. and the ER gave him something to help calm it down. But then after that wore off, it was right back to those movements again, very, very pronounced. And even from the VA or some of the other doctors trying to give him different medications, and they didn't seem to work. The other thing that he was advised to do, because it's Parkinson's-like symptoms, exercise and breathing seem to help control this and calm it down, to really focus and breathe and exercise like you have Parkinson's. So that seems to help. And then I noticed the other thing that will do it, if he would take some medications that would help with, Jeff also has ADD. So
Mhm.
if he tried to, when he wants to focus, and certain medications that have been prescribed to him, that I would call them like uppers or more speed. And if he'd start to take those and he would say, I can focus better, that would immediately start to exacerbate this
TD.
TD. And I
Right.
noticed that, and I said, wait a minute, you got something going on here. We've got to check this out
Yeah.
right away, because you don't know if your symptoms will subside if you stop taking that medication.
And like Dr. Mcintyre said, mine's irreversible as far as my knowledge is concerned. So they've tried different medications, even medications that are prescribed for TD. They can exacerbate the symptoms. And I think so those are some of the warning signs. I've seen those ads on television now, but those are some of the warning signs as well.
Josie, how common is it for people experiencing TD to feel the negative effects of stigma? How often does your organization see this or deal with this?
Sure. So unfortunately, stigma in the TD community is really prevalent. Despite the fact that more than 500,000 folks across the United States actually live with TD, it's still widely misunderstood. There's still a lot of misconceptions or a lack of awareness, and so that has a huge impact on folks living with the condition. Right? People with TD have reported feeling isolated. They've reported withdrawing from society, with reported impacts on their mental health. And so it's part of why addressing the stigma is so significant. I mean, the other thing that relates back to that is, I saw a stat not too long ago that talked about how, despite we have new treatments, so this is a treatable condition, but still 75% of people with TD have not been diagnosed. And so raising awareness, addressing that stigma is really, really important to make sure that people can treat their condition, that they can feel supported by their communities. And so that's really what, it makes it so important that the community comes together to address TD. And so to the second part of your question of what our organization does about it, the Movement Disorders Policy Coalition has been very, very active in working to raise awareness about TD, but also destigmatize the condition. We are a part of leading efforts every year around TD Awareness Week. TD Awareness Week brings together advocates, clinicians, patients, communities to raise awareness about the burden and impact of TD. And so we, every year we do a press release, we work on events. We hosted several policymaker focused events this year. We create educational materials and awareness materials, really to make sure that we're helping support the community. And so, in addition to TD Awareness Week, which is obviously important, we do work to do this work, all throughout the year. And this isn't kind of a one-time effort. It's something that has to be ongoing if it's going to work. And so we work with a number of partner organizations, including DBSA, to create materials, to create pieces that will support patients and empower them to seek care as well.
We know for people in the mental health realm and in just the medical world that access to care and education are very important to making sure that we get accurate diagnosis. So they can be barriers to care if both your medical team and just you aren't familiar with what's happening. Jeff, can you describe your experience of seeing multiple doctors, of trying to get the correct diagnosis when you didn't know exactly what was happening with you?
Originally, we thought it was my orthopedic. So we went to a lot of orthopedic doctors for my neck. I found out I had bone spurs. I had vertebrae problems, condensed or degenerative vertebrae, and arthritis in my neck. So that's what they were looking at. But nobody could do anything about it. So that was the excuse that, or the reasons that they gave that I had it. It was many, many doctors and for many, many years, because it was annoying. It didn't hurt as much as it was annoying, but it was very uncomfortable.
Dr. Mcintyre. Oh, go ahead, Cheryl. I'm sorry.
The other thing Jeff had, he had a lot of spasms in his stomach, like jerkings. That was another one that he doesn't experience now today, but he had that for quite a while. I mean, the doctors even did ultrasounds on his stomach
Hmm.
to see if something else was going on.
Dr. McIntyre, when you hear Cheryl and Jeff talk about these different diagnoses or going to different specialists and different doctors, how common is that for somebody who may be experiencing TD?
Well, first of all, thanks to both of you for really sharing the experience. And this is so vivid, and it really resonates with me because I've met many people who've had a very frustrating and similar journey. I think, look, the short answer is that that's common in the sense that many people I meet who have TD, tardive dyskinesia, have actually seen many healthcare providers, and it's not been detected, it hasn't been diagnosed. I say to them, has anyone ever talked about tardive dyskinesia with you? They go, what's that? And so on. And so the key point I think we need to emphasize strong is ask your healthcare provider, do I have TD? Can I be assessed for, everyone has to be assessed for TD. I assess for TD at every visit. And there's ways we can measure it. There's a scale called the Abnormal Involuntary Movement Scale, better known as the AIMS. So I tell everyone, ask your healthcare provider to screen you for TD. Ask them if you have it, and ask them to use the AIMS. But the other part is that, there's different types of movement disorders. Some people are born with movement disorders. They kind of run in the family. Others are on other medications that can cause tremors and movement. Some people have other medical problems like Parkinson's disease and so on. So it does require making a careful assessment because not everything that's a movement disorder is TD. So we have to make that differential diagnosis. And what's critical here is because the treatment, remember we talked about the VMAT2s, which work really well. To be clear, they work really well for TD. If the person's diagnosis is not TD, well, that's not the right treatment. And so we need to make sure the diagnosis is TD. So I think it begins with contemplation, thinking about it. And I encourage everyone, ask your healthcare provider, do I have TD? Yes or no? Can we just keep an eye on that and monitor with the AIMS? Because we have treatment. And by the way, one of the guiding principles of medicine is we don't usually screen for things that we don't have treatments for. So in some respects, I can understand why a lot of healthcare providers kind of maybe don't talk about it as much because we didn't have a solution. But we do have solutions now the last 5 years, and very good solutions at that are well tolerated, very safe. So I do think now part of it's education, because a lot of people still don't know we have a solution for this. I've met a lot of people, just to finish that thought, who I'll say to them, I noticed you have some TD, and they'll say, yeah, but I don't want to do anything about it. And I think to myself, well, that's kind of curious. I mean, it's very embarrassing for them. It can be very, distressing. And then I dig a little deeper and I find out the reason why they don't want to do anything about it is because they've been there, done that with all those things that didn't work in the past, those half a dozen to a dozen things we used to try in the past, which never really worked. It was frankly just like crossing your fingers in hopes it goes away. That didn't work either. So magic didn't work and those treatments didn't work. So we now have a treatment, people are not as aware of it, called the VMAT2 inhibitors. They should discuss that with the healthcare providers.
Dr. McIntyre, you, while you were speaking, you made me think of someone who may be taking medication and noticing that they are developing tics. Is it common for people to stop taking medication because they notice that?
What a great question. The short answer is yes. I mean, it's, look, I'll say it this way. Nobody likes to be on medication. I don't, that's very, people don't want to be on medications. Secondly, what's clearly not difficult to understand is you take a medication and you start having movement of your lips or your tongue or your muscles in some way. And in any part of the body can be involved. And nobody wants that. That's very frightening and very distressing. And for a lot of people, it can be very, not just distressing, but it can be very dangerous. I've met people who've had TD in their arms. It makes it hard to drive, or they're hard to hold a cup of coffee, scalding hot coffee. You can hurt yourself, things like that. I've met students, people of all walks of life who've had TD. And what's interesting is that some people are referred to me and it says, oh, person has mild TD. And you look at it, okay, it doesn't look that severe from my perspective. Right. That's not their perspective. And then I talk to them and they say, oh, yeah, this is called mild, but actually I don't go out on dates. I don't go on any social events. I don't give public presentations because I don't want people to know I'm on medication and I'm embarrassed by this. So I think mild is kind of a very clinician-centric. It's not really the patient's view. And what's mild, maybe not mild at all. So I ask people all the time, how is it affecting you? And what's your experience of this? And most people don't want that. Of course, they don't want that. So I think this is something we just have to screen for now, be aware of the differential diagnosis, that is the other considerations. And we got treatment, and treatment that can work very quickly, like within a week, people start to notice some benefits. And they can just take it by, this is important. A lot of people say to me, oh, Dr. Mcintyre, does that mean I have to stop my medication? Mm-hmm. Well, I mean, look, if what we say in medicine is if this medicine is causing a side effect, the best treatment is just to stop the medication. But for a lot of people, that's not an option because that medication was the one that worked. And so what we do, we add the VMAT2 inhibitors to the treatment that's helping them so they don't need to stop their medications necessarily. One final point is it's important for the healthcare provider to make sure that at least the person's not taking some drugs that can make TD worse. And one of the things that can make TD worse is what's called anticholinergic drugs. And they're prescribed very commonly. They have to be stopped because they can worsen TD. And interestingly enough, what we have found is that if you can improve, for example, let's say you have diabetes, if we can improve that, that can help your TD. Drugs and alcohol and smoking cigarettes might make it a little worse, so let's try and back off on that as well. So there's some things that we can do to help this along with the medication.
As far as access to treatment and medication, Josie, can you speak about barriers to care people may encounter?
Sure. So unfortunately, despite the fact that there are now therapies available for tardive dyskinesia, there are still a number of access barriers, which, we frequently see with newer medications. One of those barriers, I think, is actually sort of a historical one. For a long time, medications that, could treat TD were not available. Nothing had been developed or approved by the FDA. And so for a long time, what we've heard patients say is that providers didn't even mention TD to a patient who might all have those symptoms, who might be living with TD, because there wasn't a way to treat them. And so, providers wouldn't necessarily diagnose or wouldn't necessarily bring that up to a patient because what was that patient going to do about it? And so changing the mindset there, I think, is really important. This has a huge impact on people living with it. And so we need to ensure that providers have the most up-to-date information on the medications, on the treatment options, and ensure that that is brought up to a patient, especially because to the point I made already, there are so many people living with this disease who have not been diagnosed. So I think that's kind of a big picture thing that we need to address. Related to access to, therapies for TD, there are barriers. So, some of the things that we frequently see are prior authorization or step therapy. So tools that are used by insurers to limit their costs by, kind of making folks jump through hoops before getting the medication. Those are really, really challenging barriers because it takes time for healthcare providers to kind of go through all of those paperwork processes. But it also delays care for people living with the condition who could benefit from the appropriate types of care. And so those are barriers that are significant that we actually work to address at MDPC. The other one that I'll mention is just cost. Cost can be a huge challenge. There are a lot of groups that are working to provide financial support, and there are tools available for that. But any new medication, typically, the insurers work to kind of push the costs back to an individual patient who's being insured. And so, we work to address at a policy level that type of policy as well, because we know that cost is a huge burden for folks in the insurance system. And so we need to reform that to make sure that people can actually access the therapies that a clinician thinks are most appropriate.
Also, Dr. Mcintyre, here at DBSA, we talk a lot about shared decision-making with your healthcare team. How important is it for someone who is noticing, especially someone in Cheryl's position, right, where they're caring for someone or helping caring for someone, how important is it for them to speak up when they're in those appointments with their doctors, advocating for themselves?
100%. I think I take the view that whoever's living with the condition should be the CEO of the condition. They should be talking about it. They should be bringing it up to the care provider. And I can say this as a care provider, it's always welcome when people are part of the process, try to be informed, I see myself largely as a consultant to my patients and their families to be informed of the condition and its treatment. And I think the literature shows that it leads to a much more satisfactory interaction with the care provider. And I think that for most care providers, they would certainly welcome it. And thirdly, it's also, I think people feel more part of the process. It's more equitable. And I think people also would say that for them, that discussion has often resulted in treatments that have improved their overall well-being and quality of life. So we definitely recommend that at DBSA. And as a clinician, I think that with almost no exceptions, it's welcomed by the patients for sure.
Excellent. Jeff, Dr. McIntyre mentioned that, he has worked with patients who talked about the embarrassment or the self-consciousness or the stigma that surrounds dealing with TD, especially when we're talking about involuntary movements. Did that impact you at all while you were trying to seek treatment or figure out how TD was affecting you?
Absolutely. I was extremely self-conscious, and people would comment, "Are you okay?" And so that exasperated, that just added to the self-consciousness that I would be twitching all the time. So yes, the answer is yes. It was very, I don't want to say it was debilitating, but it did interfere with my social life, if you will. I elected not to go to certain places to do certain things when I didn't have to. I was high functioning and I had to work still, but it was, again, it was very I felt very self-conscious. And I'd like to say something. I agree with Dr. McIntyre 100% that people have to be a strong advocate for themselves. However, I really believe that if people are taking psychiatric medications, that should be an indication that all doctors, psychiatrists, medical doctors, everybody focuses on as far as TD. They should recognize that. That should be on the label. Watch for TD. Watch for TD. Because this is going to reach a limited amount of people, unfortunately. And doctors themselves, the medical industry, reaches a lot more. So I think there has to be a lot more education, not just to the consumer or the person experiencing TD, but to the medical field as well.
For you, Cheryl, did you notice any embarrassment or self-consciousness with Jeff as he was experiencing these symptoms?
Yes. I mean, that was on a regular basis that he would have that. Or if I noticed something was going on, I'd say to him, I don't know what we can do. Very frustrating, trying to figure out what could be done to help him. And I'm a very assertive person. So when there's a problem, I hope, that part of recognizing it, there's got to be a solution or try to figure out what can be done to assist or deal with this problem. You just can't ignore it.
What advice would you give to someone in your position, Cheryl, another care partner out there who notices that their partner is going through this?
You've got to talk to your doctor. And if the doctor recommended, if one doctor wasn't answering your questions or you weren't getting assistance, you've got to persevere. And I just can tell you, one of the last people that Jeff saw that really helped him was a neurologist who really figured out what the proper medication was for him. And that seemed to be the thing that worked, to recognize this, to know, given the medications that Jeff takes, about his medical history, that was the person who made a recommendation of what he should take, and that seemed to help.
Dr. McIntyre, if people are watching this webinar and they want to learn more about TD, the causes, the symptoms, the outcomes of treatment options, where can they go besides our beautiful website?
Yeah. Well, certainly, in fact, our beautiful website is fantastic, and certainly they should look at it. I also think, in fact, that people should always read the product monographs for the agents that are approved in this area. They're VMAT2 inhibitors. I think people should read those product monographs. A lot of it's that medical language, but that's okay. A lot of it's very digestible and so on. And there are websites, and I think people should be aware of that. There is one that, for example, Neurocrine has on Tardive Dyskinesia, which I find very helpful. I would recommend people can go to that website and have a read through it. It's got videos and information and so on. And again, coming back to this point earlier about just shared decision, I just think that people should bring it up bring it up with their care providers and say, hey, listen, have I ever been assessed for TD, or do I have that? And by the way, I like your point about, loved ones, family members, and other people might notice things that the person who has it doesn't even notice. So that's always a nice insight to have as well. So absolutely make sure that this comes up in the conversation. As I said, it affects between 10 to 30% of people who take the treatments. This is a lot of folks. And the good news is that we've got treatment that can work and it can sustain the benefits. So they don't need to make changes to their core medications, if you will, and they can just stay the course on a healthy and productive life. So for me as a clinician and as an advocate in the space, I've actually just been so frustrated on behalf of my patients when they don't receive the treatments that are available. We have those treatments that are available, and I think people just make a point of bringing up the care providers.
Yes. And Jeff and Cheryl, I know that you have a tip for people out there who may be watching this webinar, who may be living with TD, who can get a little bit of relief with your breathing exercises. Do you guys want to talk more about that and how that helped, Jeff, how those breathing exercises helped you?
I have other medical conditions also, so they help me quite a bit. And I don't know, and Dr. Mcintyre would know more than this, and I really can't answer the question, but I don't know if stress makes it worse or not. But so the breathing and the exercise, it'll help my mood disorder, definitely. And I think that relaxes the TD as well. But I agree with, Dr. Mcintyre as far as people, again, advocating for themselves. And there are medications, because I'm on a medication that obviously helps, and it hasn't interfered. In fact, it's only been more beneficial to the treatment that I already have.
Yeah, it's a great point. And I just wanted to follow that up. Absolutely, stress can make it worse. In fact, as part of the evaluation, when we're trying to determine if someone has TD, sometimes TD, not sometimes, often actually, it kind of fluctuates throughout the day. Mm-hmm. And then what happens is it's kind of like, when your light's not working, you call the electrician comes over, now your light works. Well, the light works, you don't need me anymore. Well, the problem still exists. And so a lot of times people go to the care provider, the TD is not apparent. It's kind of quiet at that time. But what we'll do some maneuvers like tapping hands, get people to do some cognitive tests, which is a way of stressing yourself really to bring it out. And so these little maneuvers, your care provider knows how to do them, can sometimes bring it out, because sometimes it's kind of below the surface. It's not obvious, but these techniques, these mental exercises or these physical exercises can really bring it out so people can notice it. So that's part of the evaluation that care providers are familiar with, and that's something that should be discussed with the healthcare team.
Yeah. Jeff said that his TD is more than likely permanent. Is that the case for all people with living with TD?
Yeah, that's good. That's a really good point. I would say it's the case for the great majority of people. In other words, for tardive dyskinesia, to what extent is it reversible? Well, there's a longer answer to that, but we'll keep it short. The best estimate is only about 10% of the time does it reverse on its own. So it can be very persistent for a lot of people for sure. And to be clear, the VMAT2 inhibitors, they treat the problem. They treat it effectively. But notice I didn't use the word cure the problem. They treat the problem. So the $1 million question is, how long should someone stay on the medication for? And what we've learned is if you take it, the studies show, take it for a year, things get better and better. But as soon as you stop it, for many people, the symptoms return very quickly. So we don't have the answer, how long should you be on it for? But what we would recommend is if it's benefiting, if it ain't broke, we don't fix it. So just stay the course and just check in with your care provider periodically. That's what we would recommend.
Well, I want to thank each and every one of you for being here with us today. We appreciate your time and insight to help us learn more about tardive dyskinesia. Thank you.
Pleasure to be with you all.
Thank you very much.
Thank you.